Assalamu alaikum everyone. Meanwhile, the participants join. I welcome you all to this online lecture series and on the behalf of PSA Karachi and I welcome you Dr. Anwar also. Okay, so I would like to introduce Dr. Anwarul Huda. He is a consultant anesthetist and director of the Obstetric Anesthesia Fellowship Program at Hamad Medical Corporation, Qatar, and also the associate professor at Qatar University. He has extensive international experience, including the positions in United Kingdom and Saudi Arabia, and he holds multiple fellowships in anesthesia, including the Royal College of Anesthesia, FCPS, and also the intensive care. He has been working currently in the Qatar Hospital, Hamad Medical Corporation. So, sir, we welcome you. And I would like to inform all the participants to kindly keep your mics muted during the lecture. And if you have any questions, kindly please put them in the chat box, comment box. We will address those questions at the end of the lecture. And I will hand over to you, Dr. Anwar. Thank you.
Okay, thank you very much for the kind introduction. So, as already mentioned, my name is Anwar. I'm currently working as a consultant anesthetist, and my lecture today is regarding the anesthesia concern for the obese parturients. So, yeah. So this is the hospital where I'm working currently in Qatar. Although Qatar is a small country, but it has got this has a major workload in this hospital because we are the referral center. We had around 20,000 deliveries per year, which is again one of the, you can compare it with any of the bigger hospitals in UK as well. So plenty of experience, and obviously we are running the fellowship as well in obstetric anesthesia. Many fellows of our fellowships are currently working as in consultant position. So let's come to the topic. So I'll try to be in a regular way, starting with the introduction and definition, classification of the obesity, followed by the different risk factors or the associated risks with obesity in the maternal as well as the fetal side. Then we'll discuss about the mode of anesthesia in these patients, and also we'll talk about the anesthesia for these patients, especially for the cesarean section. So, as you can see, it is defined as the maternal obesity is defined as the BMI of more than 30 and the first antenatal consultation. The WHO has divided this classification further on based on the number of BMI, which can be a class 1, class 2, or class 3. And class 3 is more than 40 BMI, and it's also called morbid obesity. There is another definition, more than 50, which is called super morbid obese. Although there are some threshold limitations, especially because this was developed by the WHO, but there have been few literature regarding the threshold for definition of obesity, and for Asian and South Asian countries, they say maybe 25 maybe a threshold, but again it's still in the scientific literature it is defined as more than 30 BMI. Now, as we know that obesity poses a significant risk to the mother as well as to the fetus. And this can be just related to the obesity itself. In addition, obviously, the number of the factors which are common in obesity and pregnancy as well. So there are few diseases or few conditions which are more at risk, or the patients are more at risk for these diseases. We'll start with the gestational diabetes. We know that these patients have got increased body fat and insulin resistance, so they are more at risk of gestational diabetes because of the endothelial changes because of the increased cardiac output and hypertrophy of the left ventricle. They're also at increased risk of hypertensive disorders as because of the involvement of the endothelial disease as well. They are at risk of the preeclampsia, eclampsia. So there have been different studies. They show the odds ratio of around 1.7 to 2.3 with these patients with obese patients for the risk of preeclampsia. And if you talk about the incidence, it can be from 17 to 25% incidence of the preeclampsia in these patients. So obviously it poses significant risk to the mother. Sleep apnea, which is again associated with obesity. Well, I mean, there are, because of the obesity itself, the sleep apnea is one of the risk factors for the disease, for the patient. But at the same time, pregnancy itself has some maybe you can say a positive influence on the sleep apnea, which can be because these patients are more on the respiratory stimulant side. I mean, they are more sensitive to the CO2, and that is why the effect of the sleep apnea or the apnea incidence during the sleep may be a little bit less compared to the patients without pregnancy. Additionally, the patient especially in the third trimester, they usually lie on the left side. So which is again preventing the incidence of the apnea in these patients during sleep. Then the risk of infection is more, again, because of associated diseases, also deposition of the fat tissues in the subcutaneous tissue or the skin. So the wound healing is not as good as in a non-obese patient. So all these maternal risks are obviously in association on relative to the normal patients without obesity. Because of the size of the patient as well as incidence of the macrosomia in these patients are more at risk of obstructed labor, and hence the difficult labor and difficult delivery, instrumental delivery, risk of injury during the delivery. So all these risk factors are more compared to non-obese pregnant patients. If we talk about the specific to the system, cardiovascular system, suppose if you take, they have increased blood volume, obviously increased cardiac output, which is again common in the pregnant patients anyway. But the combination of the two obviously increase the risk more. They are more at risk of left ventricular hypertrophy, increased risk of myocardial ischemia or cardiomyopathy. And because of the heart rate as well, they have a diastolic dysfunction, more likely to have a diastolic dysfunction. Aortocaval compression is another risk factor which is increased in these patients. We know about that pregnant patients, they do develop deep supine hypertension syndrome secondary to the obstruction of these major vessels. But in obesity, and especially it's more reported in the super obese patients and lying flat on or supine, increases the risk. So obviously, as in the other normal pregnant patients, this is more at risk in these pregnant patients. Pulmonary hypertension in core pulmonale is the part of their primary disease, which is the obesity. And considering these patients undergoing pregnancy, the risk increases further. If we talk about respiratory system, they do have reduced FRC, increased closing capacity, and that is why they are more at risk of desaturation and more compared to the non-obese pregnant patients. Decreased chest wall and lung compliance, obstructive sleep apnea, increased risk of difficult airway, and hypoventilation syndrome, which is snatching, which is again related to the obesity. Gastrointestinal wise, they have increased risk of regurgitation, and that is one of the reasons they are more at risk for aspiration rather than the gastric emptying, because different studies have shown that the gastric emptying is not really much affected in pregnancy. And similarly, the acid, the pH and the volume also is not that much different if you compare the obese patients compared to the non-obese patients. And most of these studies are related to the non-pregnant patients. But if they compare the two groups, they didn't find any difference. So the risk for these patients for increased aspiration risk is mainly because of the increased risk of regurgitation. In the renal, they have increased renin-angiotensin converting enzymes and renin levels. Sodium retention is more in these patients. We come to the endocrine, they are, as we said, more at risk of diabetes because of the peripheral insulin resistance. And hematological, they are more at procoagulation state and increased risk of thromboembolism, reduced immunity, and poor mobility. Now, as we mentioned about the maternal risk, there are fetal risks as well. And they are more at risk of congenital abnormalities, which include heart defects, the neural tube defects. So they're more common in the fetus. Then macrosomia, again, because of the more at risk of diabetes, and ultimately resulting in obstructed labor, instrumental delivery, birth injuries during delivery. More at risk of preterm birth, stillbirth as well. So generally, for these patients, when they come to the clinic, in either antenatal clinic or anesthesia clinic, there are different management strategies. And again, it depends mainly on when these patients come. So pre-conception counseling is very, very important, and most of the time, obviously, these are being done by the GPs or obstetricians, and the main point of emphasis on these ones is to make them understand that these patients will be more at risk, and the pregnancy will be more is considered as a high risk. So they have to be prepared for all these consequences. They need to know that nutritional and lifestyle guidance can help quite a lot in terms of the weight gain during the pregnancy. And they need to, and again, the pre-antenatal clinics are the best for these guidance. Prenatal care. So again, in antenatal care, it's very important that these patients, especially when talking about the morbid obese patients, that these should be consulted by the anesthesia and the Royal College of Anesthetists and the Royal College of Obstetricians and Gynecologists. They have recommended that these patients should, we are talking about the morbid obese patients, they need to be assessed in preferably in the third trimester, early trimester. And then at that time they will be assessed properly. Their communication properly is done. Not only just for their labor, and then GSD also for the chances of cesarean section and how their anesthesia will be managed during cesarean sections. All these communications need to be done. The usual the risks which are associated with the pregnancy, like pedal edema and shortness of breath, should be taken very, very seriously in these patients. And although they can be associated just like as the same in the other pregnant patients, but these patients are with the obese pregnant patients are more at risk of these, and very, very low threshold should be made for ordering any ECG or the echocardiogram if you are suspecting or the patient is complaining of anything, which may be usual for pregnancy, but in these patients we have to be a bit more careful, because in addition to the pregnancy-related or obesity-related changes, there can be some underlying cardiomyopathy, which, as we said, that these patients are already at high risk of pulmonary hypertension and pulmonary. Physical activity, then again, there has to be communication in the antenatal time with the obstetrician, with the physiotherapist as well, regarding managing their physical activity, and multidisciplinary team depending on any other medical condition that the patient has. So we manage accordingly. So delivery planning should account for the increased likelihood of cesarean delivery and need for the specialized anesthesia consideration. And the postpartum time also should be emphasized, and the emphasis should be on managing the weight, preventing the postpartum depression, and addressing any lasting complications for pregnancy. And early and comprehensive perinatal care is crucial to managing risk and improving outcomes. So coming to the anesthetic management of the vaginal delivery. So the anesthetic team must be involved early in the interpartum care of morbidly obese patients. So in general, obese patients should be consulted early. And as I mentioned, that ideally, especially the morbid obese patients, they should be consulted in the third trimester, early third trimester. And in addition to that, when the patient is actually admitted to the hospital for the labor, for the delivery, the duty anesthetist and the theater team should be made aware of, because as we said, the increased risk of severe infections in these patients, increased risk of instrumental delivery in these patients, and need to be prepared beforehand. And any antenatal care consultations which have been done and ideally should be documented as well, that needs to be reviewed again and re-discussed again. So there might have been changes during the course of time, and they need to be aware about these changes, and then also the plan again re-discussed at that time. Now, one of the very important consideration in these patients is difficult IV cannulation. So early IV cannulation is recommended, and we know that these patients are at risk, so ultrasound can be used especially for identifying the deep veins. So it's very handy in these situations, so we can get the IV cannula. And then in certain cases, central venous cannulation is required as well. Labor analgesia should be discussed, and although there are other options as well, but the recommended for these obese patients, and especially the morbid obese patients, the epidural for labor analgesia. But at the same time, we need to be aware that the epidural failure rate is much, much higher. So the incidence varies. Like in the normal pregnant patient, the incidence is around 1%, but in the pregnant obese patients, it can go up to 4%, so which is relatively higher. And the reason could be different. So these patients obviously are difficult in terms of the palpation. Landmarks are not easily identifiable. And usually, I mean, for these patients, we either look for the seventh cervical vertebrae or the gluteal cleft in order to identify the midline. And most of the time, the midline is the main issue, which can be problematic in performing the epidural or any neural block. Another important thing is the positioning of the women for the epidural insertion can be very, very challenging. These patients are not very good at flexing the back, so the opening of the spaces are not as good. So again, also the depth from the skin to the epidural space can be too much. So again, that can be a problematic factor. That is why the ultrasound is usually preferred, and like in our institute, most of the labor obese patients, especially the morbid obese patients, will undergo the pre-epidural scanning with ultrasound, and then we mark the space, and then accordingly we'll do the epidural. So that has, I mean, again, it also depends on their skills, but again, that really helps quite a lot in morbid obese patients, because sometimes you can't really feel anything on the back. And again, morbid obese patients can be of different types. Some patients do have a big fat in the back, just at the point where we injecting the epidural needle. But in some morbid obese patients, you may not find that much fat pad, and the structures are more easily palpable. So it can vary. But again, if you use the ultrasound, that makes all that quite easy. Another consideration is the use of the longer needles, because as I mentioned, that the depth can be quite a lot compared to the normal pregnant patients from the skin to the epidural space. So we have to have in hand the longer needles for the spinal as well as for the epidural. In this case, obviously, we are talking about the epidural, the longer epidural to need as well. In addition to that, another factor which is very important in these patients is that once the epidural needle is in place, before and the catheter is being inserted, we need to be aware that before actually fixing the epidural catheter, we have to make the patient relax because as we say, the patient, if it's in the flex position, so because the content of the epidural of the fat on the back is so much that if the patient gets relaxed afterwards, after the catheter placement, I mean in the flexion position, and then patient gets relaxed, and then we keep the catheter in there, then there are chances that catheter might get pulled out. On the other side, if the epidural catheter is fixed on that position, it might go in. So anyway, so if we don't fix the epidural catheter while the patient is relaxed from the position in which the epidural catheter was placed, there is a risk that epidural catheter might get pulled out. So you have to be very careful about that, and fixing should only be done once the patient gets relaxed, sitting properly, and then we should secure it. And some people recommend that you should keep a relatively increased length. So ideally, there are different schools of thoughts. People put it at 3, 5, 7 centimeter. We usually put it at 5 centimeter, but in this situation, you might put it at 6 centimeter, and then if there is a margin of 1 to 1.5 centimeter that comes out, even then it was still in place. Combined spinal epidural is another mode of analgesia which are used in some units. Like in my hospital, mostly we use the epidural only, but there is another technique which is called DPE, dural puncture epidural, which is nearly similar to combined spinal epidural, but we don't give the medication in the spinal. So that's only different, but we got the surety that the spinal, we have got the CSF from the spinal needle, so the reliability of the block definitely improved. In certain situations, because as I mentioned, the accidental dural puncture in these patients is relatively more. I mentioned the incidence is 4%. There are different recommendations. So if the patient has got difficult epidural, 2-3 attempts have been done already, and at that time, if there is a dural puncture, then taking it out and putting another epidural obviously increases the risk for another puncture. So most of the experts would recommend that the catheter should be kept in, and it should be used as a continuous spinal analgesia. But again, it has to be monitored very cautiously, because as long as the setup is well tuned to do this, then only it should be attempted. In my institute, we do practice this. We do use continuous spinal analgesia. Continuous in a way that we don't use the infusion. We just give the boluses, which can be a bit troublesome for the anesthetist on call. Like sometimes it has to be given every 1 to 2 hours, so 1.5 to 2 ml every time patient complains of pain. So it has to be delivered by the anesthetist and then monitored by the anesthetist, especially just after the bolus. So this is a bit cumbersome in certain situations, but again, for these patients, it's worth doing it because we are avoiding the risk of another dural puncture again. Although the studies have shown that the incidence of the post-dural puncture headache in these patients after accidental dural puncture is not as much as compared to the non-obese patients. The reason could be different. The theories are there that like when the obese patient, because of their increased abdominal pressure, the transmitted pressure in the epidural space prevent the leak, and then the risk of post-dural puncture headache in these patients is relatively lesser as compared to the non-obese patient. Another advantage of these intrathecal catheters that it can be used for the top-up during the operative delivery or any other procedure like instrumental delivery. So another mode of analgesia in normal pregnant patients is for patient-controlled analgesia with opioids, and most of the time it's the remifentanil. but in morbidly obese patient is not an advisable strategy. The reason are many, and the main reason is basically that they are more at risk of respiratory depression, and because of their anatomy and the respiratory condition, they are more at risk of desaturation. So that can be detrimental for the mother as well as to fetus. Additionally, the physiological effects of these opioids, their pharmacokinetics and pharmacodynamics are also different compared to the non-obese patients. Even the devices which are used for delivering these opioids have got limitations because of the weight, and also pharmacokinetic models are not very much in according to the morbidly obese patients. So it might not be a safe or and reliable option in these patients. So as I said, epidural analgesia would be the ideal analgesic technique in these patients. And as I mentioned, that combined spinal epidural is another option. Now, management of labor. So management of labor should be done very actively in the third stage, especially because we know that these patients are at increased risk of postpartum hemorrhage because of many reasons, like operative injury, birth injuries, just because of the big size of the fetus, and also because of the size of the fetus, they are more at risk of uterine atony. So all these factors increase the risk of postpartum hemorrhage, and therefore the management should be very active, and also the availability of the blood should be immediately available and administered early as soon as it's required. Ureterotonics should be used as a bolus and infusion. Point of caution is regarding the ergometrin, because we know that these patients are at high risk of hypertension or preeclampsia, so ergometrin can be a risky thing in these patients because it increases the risk of vasoconstriction. So they should be used with very cautiously. Now, coming to the anesthesia for cesarean section, as with other pregnant patients, neuraxial anesthesia remains the preferred modality. Epidural topped up in urgent cesarean section or emergency cesarean section if the patient has got already indwelling cesarean epidural catheter. We need to make sure that it's working effectively. Before we decide about this, we need to check it appropriately. So sensory checking with the cold touch and spray, and also tactile stimulation should also be used, because once the epidural catheter, we have planned to use it during the surgery, and we have started and surgery started, and then converting to the general anesthesia during that situation can be extremely difficult or extremely dangerous to the patient. So we need to make sure that if we are planning to use the epidural catheter, then it's working very, very effectively. Or in situations where the catheter we are not sure about, better just take it out and then use either a spinal or in morbidly obese patients combined spinal epidural. Regarding the dose of local anesthetic, if you are using it for the top-up, it should be calculated according to the ideal body weight. Volumes may be a bit lower, and the reason being that different MRI studies and also theoretically, because of the increased abdominal pressure, the transmitted pressure in the epidural space, and also congestion of the epidural veins, that reduces the volume in the epidural space, and that's why the volume requirement may be lesser than the normal obese patients, pregnant patients. And epidural opioids should be used to augment the block and prolong the duration of anesthesia or the analgesia. Another important thing that keeping the epidural is important, because we can always top it up if the surgery is that prolonged, which is again these patients more at risk for. Single shot spinal anesthesia. So regarding single shot spinal anesthesia, we know that this is the more common way of anesthesia in any of the cesarean section, and the reason being its familiarity. As provides a reliable block with a rapid onset, and a reasonable option is an urgent cesarean section. But we need to know that we need a longer needle, and sometimes the introducer might not be enough to handle that long needle. So in some situations, you might have to use the epidural, the 2V needle as an introducer, getting the epidural space with that needle. Or even if you're not getting it, at least use it as an introducer and then use the spinal needle through. But obviously there are disadvantages as well, that because we can't top it up, if in case the surgery prolonged. So the decision regarding anesthesia for these patients is extremely important, especially the morbid obese patients, the super morbid obese patients. We have to make sure that whatever we are planning for, we have to take into account the condition, the situations which can happen later on, because generally these patients require a longer surgery. And another thing is that we can't titrate the spinal dose. Regarding the dosage for the intrathecal local anesthetics, most of the studies comparing the obese and the non-obese patients, and even up to the morbid obese patients, the dose requirement, although the epidural space, because of the smaller epidural space, the requirement is lesser in those patients, but the spinal requirement usually is the same. And also, we don't want to take a risk of using a smaller dose and then the effects of the spinal bearing of early. So usually, and most of the recommendations are there that the spinal dose for the morbid obese patients should be the same as for the obese or the non-obese patients. Although in the super obese patients, there have been different case reports which have mentioned that even with the standard dose, the incidence of high level or the incidence of hypertension is much more. So, I can give you the example in my institute that for the super morbid obese, we usually prefer the combined spinal epidural, which is why this technique is considered more of a gold standard for the morbid obese or super morbid obese patients. And the advantage is obvious, because it provides a reliable anesthesia with a rapid onset, the spinal component, and also it can be extended using the epidural component. Another important thing is that we can use a smaller spinal dose. That can be helpful for the morbid, super morbid obese, and also for the patient if they have got any underlying cardiac disease, which these patients are more at risk. Preferred in cases where opioids are considered high risk, which again these patients are. But again, there are disadvantages that possible failure to pass the epidural catheter, slightly higher failure rate of the spinal component, and the usage of an untested epidural catheter. These are like this one is more of a theoretical one, but most of the different studies they have mentioned that even if we don't test it, the reliability is still quite good because we have already checked the spinal, and if the spinal is working, it's only done after utilizing the epidural catheter, after identifying the epidural space. As I mentioned before, that spinal anesthesia can also be, a spinal catheter can be used for the labor, and similarly, it can also be used for the cesarean section if the patient undergoes cesarean section. Although it's rarely used as a primary anesthetic plan. So it's only in those situations where the catheter is already in place, and it has been used for the labor, and the patient suddenly goes into some compromise, fetal compromise or maternal compromise, and then patient is rushed to the theater for emergency cesarean section. But again, it has to be managed very carefully. And the risk of high spinal or total spinal is there. And obviously, in these patients, this is a significant risk considering their respiratory function is already compromised with the pregnancy, with their obesity. You don't want to add another factor and increase the risk of respiratory depression or arrest during the surgery. Another technique which is called double catheter technique. It's not a very common technique, and there have been a few case reports reported in the literature, but there is a logic for using this technique, like in patients who are having a very high BMI, like maybe supermorbid obese, and where the surgeon has planned for rather than fenestrial incision, they plan a midline incision. So in those scenarios, obviously, using only the number epidural might not be enough for achieving the good level of anesthesia, especially at the upper end of the incision. So in those situations, the technique which has been used in the several case reports, that they use the lumbar combined spinal epidural and the low thoracic epidural for covering the upper part of the incision, and also for the postoperative pain, because obviously these patients with these midline incisions, it will be affecting their breathing efforts postoperatively. So that epidural can also be used for the postoperative pain. Then another mode of anesthesia for if these patients are undergoing cesarean section, and if there is some contraindication to the spinal or the epidural, or it has failed, then the only other option which is reserved, which is general anesthesia. Sometimes the only option when faced with a non-obstetric surgery, like pregnant patients undergoing some emergency laparoscopic cholecystectomy, emergency appendicectomy, or laparoscopic. In these patients, antacid premedication is extremely important, using H2 receptor antagonist or the pantoprazole, proton pump inhibitor, along with the sodium citrate. But we need to know that the sodium citrate duration of action is not more than 45 to 60 minutes. So even if you are using it, we have to use it very close to the start of induction. Positioning can prove to be a challenge, and especially there are different consideration in terms of different risks in these patients. Less lateral tilt is needed for these patients just to avoid the caval compression. But in case of the obesity, morbid obesity, you probably need the sitting up position or the ramped up position for the better management of airway or the more comfort for the patients. So these position needs to be managed in accordance with the patient requirement. But left lateral tilt always should be the first priority. And if the patient is undergoing general anesthesia for better management of airway, ramped up position is again very helpful. And usually the Oxford head elevating laryngoscopic pillow help is recommended for these patients for airway management, or we can use multiple pillows just to make the similar situation. Operating tables, while we are doing these cases, we have to be much aware about it, because there is a limitation of the weight on every operating table, so we need to take care of this thing. Extra staff should be available. Monitoring again is very important. Sometimes some additional monitoring may be necessary. And especially I'm talking about the blood pressure cuff size, and usually recommended the length of the cuff should be more than 20% of the circumference. And if it's smaller, then we overestimate blood pressure. And sometimes you might have to put it on the forearm, and which has good correlation in most of the studies. And then invasive blood pressure monitoring may be needed in certain situations. Fetal monitoring again can be difficult. So this is the Oxford pillow. Our aim is to keep the tragus or the head canal and the suprasternal notch in the same plane. That's the main priority for aligning these patients in order to improve the airway management of these patients. Coming to the anesthetic drugs, we need to know that we have to have a good knowledge of pharmacodynamics and the pharmacokinetics of these the different drugs which you use during the general anesthesia. And general recommendations and the medications which are commonly used for anesthesia for the cesarean section, the succinylcholine. Total body weight should be used. Lean body weight should be used for the induction agents like the thiopentone, propofol, and opioids. And ideal body weight should be used for the muscle relaxant and the fat storm and NSAIDs. Nowadays, the propofol is more of a common induction agent because of multiple reasons. I mean, there have been incidences when the thiopentone was used without actually mixing with the medications. And because of these critical incidents, propofol is usually the preferred option nowadays in most of the places. Rapid sequence induction is the preferred mode of induction. And difficult airway, we need to consider always is more likely in morbid obese patients, and also that's the reason that in the muscle paralysis we have to be very specific, and it needs to be a short duration muscle relaxant, and also should be the one which can be reversed. And over the years, succinylcholine is the classical muscle relaxant used. But nowadays, with the availability of the rocuronium and also the muscle and the reversal of the sugammadex, it's gradually replacing succinylcholine for rapid sequence induction in obstetrics. But again, there is a problem with this, the expenses of this medication, because if you see that the dose which is used for the immediate reversal, which even take about maybe 90 seconds to 120 seconds, it will need a dose of 16 milligram per kilogram, which means that tool is about 200 milligram. So we'll need, if in 100 kg case of a patient, we'll need about 8 ampoules. Which I remember in UK when I was using it until 2019, the cost was 80 to 90 pounds for 1 ampule. So obviously, if you're using it for immediate reversal, it costs quite a lot. So this consideration has to be in mind. I'm not sure about how much it costs in Pakistan, but again, it's an expensive medication. Then maintenance of anesthesia in morbidly obese is achieved by the inhalation anesthesia. These are the different formulas which are used to calculate the ideal body weight, lean body weight, and adjusted body weight. Now, physiological changes of the pregnancy were the difficulties encountered when managing obese patients, especially if you're talking about the airway. If we look at the NAP4, which was done mainly to detect or assess the problems associated with a difficult airway, difficult intubation, failed intubation, it has identified 4 cases of obstructive difficult airway, and out of 4, the 3 were obese patients. So we can see that obesity does pose a significant risk for the difficult airway. And that is why these patients require a detailed airway assessment, careful planning and preparation, and communication with the team. It should encompass the prediction of the difficult tracheal intubation, mask ventilation, supraglottic airway device insertion, front of neck access. And in this scenario, the use of ultrasound is extremely important. And at least it will help in identifying the mask ventilation using the size of the tongue. And also we can identify the front of neck axis, thyroid membrane we can identify, and we can actually mark it before actually starting the airway management of these patients. So nowadays, the ultrasound is extremely important in assessing these patients. And in certain situations where time allows, awake intubation using either fiber optic scope, or even nowadays, even the region laryngoscope is being used in awake patients with some local anesthetic applied in order to avoid the risk associated with induction followed by difficult intubation. The Difficult Airway Society and Obstetric Anesthesia Association will have recommended an algorithm which includes algorithm 1, 2, and 3. The algorithm 1 is mainly the pre-induction planning. The 2 deals with the failed tracheal intubation, and the three can't intubate, can't oxygenate condition. So if we talk about the preoperative preparation, it includes airway suspense, fasting status, and acid prophylaxis, and intrauterine fetal resuscitation is appropriate. And then obviously the plan with the plan communication with the surgeon, with the team, and if needed, might have to be keeping available with the ENT surgeon. Then if the case in the algorithm when the tracheal intubation is failed, then we have to use as according to the guideline, supraglottic airway or the face mask, if oxygenation is adequate. Then we have to think about that whether shall we wake the patient up or the proceed with the surgery. And then the algorithm 3, which deals with the can't intubate, can't oxygenate, and ultimately it ends at the same point that if the oxygenation is good enough, then you have to decide whether the patient can be woken up or should we proceed with the surgery. Now, the important considerations which are needed and then which are needed to actually decide about whether we are proceeding with the surgery or we waking the patient. So these are the conditions, which are maternal condition, fetal condition, the grade of anesthetist, the obesity, the type of obesity, whether it's super obese, super morbid obese, only obese, or the normal surgical factors are there, the aspiration risks, how much we are expected in these patients. And based on these, like if I take the example of the maternal condition, that if there is no compromising possibility will be waking up the patient, and if there is a hypovolemia because of the blood loss or cardiac critical condition, which can compromise the heart and compromise the patient, then most likely we'll go ahead with the surgery. The new recommendations regarding the airway management recommend the use of nasal oxygenation to administer oxygen during apnea to increase the safe time. And especially nowadays, Optiflow, which is the high flow nasal oxygen, which has been used to increase the apnea and safe apnea time. In number of institutions, like in my previous hospital, we used to use this high flow nasal oxygen for all general anesthesias used for the cesarean section. But again, it's usually helpful for the morbid obese patient, and if you see there is no specific guideline about it, but they do have mention about its use. And obviously the time of safe apnea time, which means that starting from induction up to the point when the saturation drops to the critical level, like 88-90%, it usually is increased in use of high flow oxygen. Then video laryngoscope increase the success rate of these intubation and should therefore be always available and be used in the obese patient, and preferably used as a first-line option rather than using as a backup, especially in the obese patient or the morbid obese patient. A significant proportion of the airway-related complications arise during the emergence of anesthesia. So that again is the case for the patients with the pregnancy, and that is why, and one of the reasons also because these patients are relatively slower to recover. And that is why we need to give full time for these patients to wake up, adequately reverse, and are in the ramp position. Only then we should be attempting extubation. And in certain situations, you might have to, in patients who might have problems with the oxygenation or where we might have used strategies to improve the oxygenation during the surgery, might have to consider the use of the CPAP at that end of after the waking the patient, or maybe the use of the high flow nasal oxygen and transferring the patient and setting up position to the recovery room. Regarding the postoperative care, it's again very challenging in morbid obese patients, and the main challenge is related to their not only just their surgical reasons because of more risk of bleeding, and also for anesthetic risk, which again because of the inadequate pain control, and because we have limitations in terms of utilization of the opioids in these patients. But again, the management is the same, the multimodal pain management, but we have to be careful with the use of the opioids. Nowadays, the regional anesthesia is taking care of a lot of these patients with with very much well-known techniques nowadays, and everybody is getting more skilled in utilizing these and techniques like the tab block, erectus spiny plane block, the projection bone block. Would like to just mention here that we did a meta-analysis comparing the analgesic techniques, received anesthesia techniques, including the tab block, comparing with the quadrilateral bone block and erectus spiny plane block. And erectus spiny plane block seems to be a better modality of the renal anesthesia technique for pain control in first 24 hours. Again, it's comparable to the quadratus lumborum, but again, it depends on what type of quadratus lumborum block we are doing. It's not as effective for the lateral technique, but again, for the anterior and posterior, they are usually nearly equivalent to the erectus spiny plane block. So these blocks are recommended for better pain control in morbidly obese patients. An important thing is that these patients need close monitoring in HDU settings in order to avoid all these complications which have been discussed already. Another important consideration in these patients is the incidence of the DVT in these patients and the risk of thromboembolism. There have been different recommendations, like American College of Chest Physicians. They have mentioned that they consider the obesity as a minor risk. And if there are two minor risks or one major risk, they consider the prophylaxis with either mechanical or the pharmacological using Clexane. So unless the patient is undergoing emergency cesarean section with obesity, they will only use the enoxaparin. Otherwise, if you talk about the Royal College of Obstetricians and Gynecologists, they are more liberal in utilization of the pharmacological management, treatment of utilization of the Clexane or the enoxaparin. So any patient who are morbidly obese, they will get Clexane, whether they are undergoing cesarean section or vaginal delivery. And in the obese only, not morbid obese, only obese patients, but if they are going for either elective or emergency cesarean section, they should receive the Clexane. And they usually recommend it for 10 days. So it's a bit different in the guideline between the two. These are the references for my presentation, my talk. So let's come to the take-home message. I will conclude it by saying that obese parturients are high-risk group of patients, and early prenatal care involving anesthetics as well is crucial to managing risk and improving outcomes in these patients. And anesthetic must be involved early in the intrapartum care of morbidly obese women. And airway management of these patients should include a comprehensive plan. Thank you very much. And if any question, I'm happy to answer.
Thank you, Dr. Huda, for sharing your valuable insights. And we have two questions in the comment box. So one was about the DVT prophylaxis, which you have just mentioned. But Dr. Latif is asking, why not heparin?
Well, heparin in those situations, usually, and most of the recommendation, if you see, is low molecular weight heparin is recommended. And heparin is recommended in situations, but again, the incidence, we know that the incidence of the hit is more common with the heparin. So that's why the Clexane is usually a preferred option in most of the recommendation, Clexane or enoxaparin.
Hope that answers the question. There's another question, recommended mode of ventilation in obese patients undergoing general anesthesia.
Well, it depends. Personally, I usually start with the volume control, pressure regulated mode of ventilation. But if I feel any problem in ventilating, I usually switch to the pressure control and utilizing the inverse ratio ventilation, depending on how the patient behaves. So in some pregnant patients, some obese patients, the ventilation might not be a big issue, but again, in some situations, we have to. So there are different strategies we have to use. We have to use a slightly higher tidal volumes. They usually recommend 6 to 10 ml per kilogram. They recommend the high utilization of the PEEP until 10 centimeters of water. And again, periodic inflation with the manual. Can you hear me? Can you hear me? Hello? Hello?
Yes, we are hearing.
Yeah, okay. I hope that answered the question. Any other questions?
Yes, there is another question. Is there any difference in doses of opioids used in spinal epidural or morbidly obese, keeping in view the respiratory depression?
Well, that's an interesting and important question. So regarding the fentanyl, usually there is not much difference. I mean, in my institute, we use 10 to 15 microgram in the spinal. And obviously the solution for the epidural is generally the same. It's 2 microgram per ml of the epidural. But while we are using the intrathecal morphine, that has got different recommendations. Again, the diamorphine, which is again commonly used in UK, we used to have the same dosage for both the obese patient and non-obese patients. But the morphine is especially important in these patients because morphine has got the tendency to cause the late respiratory depression. And as long as there are protocols in place, these patients can be given intrathecal morphine. We have recently started using the intrathecal morphine because we were using before intrathecal fentanyl. I have got the experience of using intrathecal diamorphine in UK. The morphine, the issue with the morphine, and at the moment we are using is as a contraindication, doing the intrathecal morphine for the morbid obese patient. But if you look at the recommendation, as long as we are using as in the dose of 75 microgram to 100 microgram, we just need to increase the duration of increase the frequency of the monitoring in the post-operative period. And also, preferably, if the patient has got morbid obesity, it should be monitored in HQ setting. So there are some differences in terms of monitoring, but as long as the system is in place to detect these patients, any problems post-operatively, this can be used. And usually this dose is called the low dose or ultra low dose morphine. But generally, more than 100 microgram is not recommended anyway for any severe infection. So I would just say that in the morbidly obese patient, the dose should be either reduced to half or maybe 2/3. But it's only in the case of the morphine, intrathecal morphine.
Thank you. We will just take one quick question. Role of focus in obese patients. This will be the last question, Chair.
Role of focus, I mentioned already that the focus is, again, the part of the airway assessment is actually part of it. So, in most of the workshops where we go, where we learn the focus, the airway assessment is very crucial. And as long as the airway assessment is done using ultrasound before managing these patients for the general anesthesia, it does play a significant role.
Thank you, Dr. Huda. Thank you very much on behalf of the PSA. I would like to thank everyone who has joined us today. And we'll be finishing this lecture for today. And we'll see you all again in the next lecture, inshallah. Thank you, sir.
Thank you very much. Thank you.